we're here to touch the lives of people who are suffering with eating disorders and transform them in a way that leads them to health and wholeness and full recovery. I'll be speaking today. I might be a little short of breath. I'm a little over 8 months pregnant. But I'll be speaking to you today about identifying and assessing eating disorders, specifically in adolescents and young adults, with particular focus on some of the differences in assessing that patient population, because it's not the same as treating or assessing or identifying an eating disorder in adult populations. We'll speak a little bit about prevalence in adolescents. We'll review some of the signs and symptoms of each of the main eating disorders. We'll talk about risk factors, assessment tools, specifically those that have been validated in adolescent and young adult populations, clinical examination, and then treatment options. I'm guessing probably in an hour we're not going to have time for a full case study, but I will be including case examples as we go along. And I'll leave some time for questions as well. About 500,000 teens struggle with eating disorders, and the average age of onset is around age 12 to 13. Many of those who struggle show no outward signs, so it's a very difficult thing to identify, especially if you don't know some of the more subtle signs of a person engaging in eating disorder behaviors. Many primary care physicians, many pediatricians, many family practice physicians have had little to no training whatsoever when it comes to eating disorders. And unfortunately, these are the people that are most likely to have contact with patients suffering in silence from eating disorders. Parents, many times, are the people who bring their children to these primary care providers. Sometimes their concerns are discounted. Sometimes their concerns are explained away by other factors, such as a common one that we hear a lot is, your daughter has a heart rate of 45 because she's an athlete, because she runs 2 hours every single day. And she's a straight A student and she's doing great, calm down, medically, she's fine. So many times these are overlooked and missed. And one of the things we know from the research is that early intervention yields the best outcomes. The shorter the amount of time spent in the disease, the better the chances of that person fully recovering, and sometimes in a relatively short amount of time. It's much easier to treat a 16-year-old who's been sick for 3 months or 6 months than a 35-year-old woman who's been sick for 20 years. These are not just phases of adolescence. It's not just an expression of vanity. I think as a field, we've done a good amount of work in increasing awareness and dispelling the myths that many times surround eating disorders. Eating disorders are also equal opportunity diseases. All ethnic and socioeconomic sectors of our society are affected. This is recent prevalence data showing about 0.5% of adolescent girls in the United States have anorexia. 1% to 2% meet diagnostic criteria, full diagnostic criteria for bulimia. This increases to about 5% to 7% if we include sub-threshold eating disorders, anorexia, bulimia, binge eating disorder. And 5% to 10% of all cases of eating disorders are males. There's more and more awareness of males being affected by eating disorders, and unfortunately the treatment resources specific to males are a little bit lagging behind. We have relatively a lot in the way of gender-specific treatment for women with eating disorders and girls with eating disorders, and a lot less resources for boys and men with eating disorders. This is data that was published in 2014 from the National Comorbidity Survey replication study, specific to the adolescent population. But what does an eating disorder look like? Not to say that people look like bottles, But I don't want to, I think a lot of times in the work that we do, we can sort of collude with I didn't want this to be a pro-Anna picture up here. So all shapes and sizes, all different colors. That's what an eating disorder looks like. There's no particular weight, there's no particular color, there's no particular gender. Okay, now back to the National Comorbidity Survey. This was published in 2014. Daniel LaGrange and his group out of Chicago did this study. Median ages of onset for all of the eating disorders categorized by DSM-5 criteria were around 12 years old. We have seen a trend of younger and younger age of onset. Some of that may be greater awareness. Some of that may be increasing capacity of parents, of doctors to identify and treat eating disorders, which is good news. There's a significant amount of psychiatric comorbidity in patients with eating disorders, and particularly so with eating disorders that involve binging behavior. So bulimia nervosa, binge eating disorder, also subacute or subthreshold anorexia nervosa had comorbidities in the ranges of 70 to 80%. And to treat patients to recovery who have eating disorders, it's absolutely essential to identify and treat the co-occurring disorders as well. So we cannot be tunnel visioned in our work as eating disorder professionals. Further, in adolescents with bulimia nervosa, about a quarter of those had 3 or more co-occurring disorders, and those with binge eating disorder, 37% had 3 or more co-occurring disorders. And this is the classic patient that that's sick enough to meet criteria to come to a residential treatment center like TK. Most of our patients have 3 to 4 axis 1 diagnoses. Suicidality, as Dawn talked about in her own community, is a major cause of premature mortality among this population. And we always, always, always need to be in the back of our minds assessing for risk factors for suicidality and explicitly asking about it, because this is not something a patient's going to come into your office and say, hey, by the way, I'm thinking of killing myself. It's probably the last thing, as a psychiatrist, many times it's the last thing that patients say to me, because they know that I'm obligated by my license to commit them to an inpatient psychiatric unit against their will if I have reason to believe that they're imminently at risk of hurting themselves. So with bulimia and subacute anorexia nervosa, they were further associated with suicide ideation, suicide plans. So not just thinking about suicide, but we also have to ask, what specifically are the thoughts? Are you in a place where you're saying, I just don't feel like living anymore, I wish I could just go to sleep and not wake up anymore? Or is it the next step further where you're saying, I've been considering going to the Home Depot, buying a rope, tying it up to my ceiling fan? Somebody who's gone as far as to have a specific plan is a different risk category than somebody who's thinking about suicide. And then further, we need to assess intent. Is this something that you are intending to carry out, or is this something that you're just thinking about and have made plans? Both of the two latter categories are people who really need to be considered for inpatient treatment. And many times with adolescents, I hear this over and over and over again from sometimes from referral sources, sometimes from parents. She's kind of dramatic. She's attention seeking. She's saying it's more than it really is. This was really just a cry for help. She wasn't really, gonna do any of this stuff. We walked into her room and she had a rope around her neck, but she knew we were home. So people tend to make all sorts of excuses for this and try to minimize this, because it's so absolutely terrifying for a parent to imagine that their daughter could actually go through with killing herself. And unfortunately, up to, in some studies, up to 50% of patients with anorexia die by suicide. So it's something we always take very, very seriously, regardless of whether it's attention seeking or an adolescent glorifying. In my experience, most adolescents don't glorify the suicidal piece of this. So more than 50% of adolescents with bulimia nervosa had suicidal ideation, and more than a third of those with bulimia nervosa had suicide attempts. So again, particularly in the eating disorders where there's that impulsivity piece and loss of control piece associated with purging behavior, we see higher rates of suicide thinking, suicide attempts, and completed suicides. There are a couple of things to keep in mind, particularly when assessing adolescence. First of all, medical problems can arise even with a small amount of weight loss and a small fall off from the growth curves. Children and adolescents also do not experience their bodies in the same way that adults do. So they may lack the vocabulary for some of the typical eating disorder thoughts that you would hear from an adult patient with an eating disorder. Adolescents and young adults still have very much developing brains. Their brains are in progress and in process, and particularly so with regards to executive functioning, or the orbitofrontal cortex, which is the area of our brain that we use to do things like determine short-term versus long-term goals, short-term versus long-term rewards. I feel terrible right now. In the short term, I know I could purge and it'll go away instantly. In the long term, I know that if I keep doing this, my parents are gonna send me away to a place like Timberline Knolls. Adolescents don't have the capacity to make those sorts of decisions. They don't have that space between thought and action that we have with fully developed frontal cortex. Further complicating assessing adolescence is the fact that most of our diagnostic tools lack any sort of age or developmental specific criteria. So, there's nothing in the DSM-5 that says, by the way, adolescents might not have the cognitive capacity to tell you, that it was an objective binge eating episode because they ate a full bag of groceries. Adolescents lack the specificity and the detail sometimes that we solicit when making diagnostic decisions based on things like the DSM. Physical criteria are also different. Unlike with adults who have eating disorders, the use of BMI to assess proportion of ideal body weight or goal weight in treatment is oftentimes inappropriate and inaccurate with adolescents. Most of the methods to assess ideal body weight do not take into consideration things like body stature or family history of body stature. These are things that are critical to include not only with adolescents, also with adults, but we also need to know that with adolescents, using things like the growth curve, having an adolescent on a 25 percentile growth curve and falling off of that is much more significant than having an adolescent on a 50% growth curve or 100% growth curve and staying on that. So you want to look at deviations in their pattern and historical data, much more so than BMI at any snapshot moment of time. And again, what we see with many, many medical professionals who are doing the yearly physicals is, your BMI is 18, you're healthy, that's great. We have an obesity epidemic in our country. Or your BMI is 22. Mom, you might want to put, make sure he watches what he eats, make sure yada, 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 versus how much physical activity is he getting? Is he physically fit? What are his eating behaviors? Is he eating a wide range of food? Is there balance and moderation? So there's an over-focus on BMI, particularly with adolescents, and particularly with all of the hoopla in our culture right now about the obesity epidemic, specifically in children. With regards to cognitive criteria, because of their developmental stage and ongoing brain development, adolescents have a much different experience of the cognitive symptoms of anorexia and bulimia. In anorexia, particularly cognitions around current body weight or fear of fatness are often not reported. Sometimes they're not experienced by adolescents. In bulimia, adolescents tend to have a different experience of the loss of control of the binge eating episodes. Many adolescents say they don't feel like they lose control. They just do it because they want to do it. Many adolescents with anorexia say they just want to be thin. They don't think they have an eating disorder. They're not afraid of being fat. They don't think that they're fat. They just want to be thin because they want to be thin. This is different than what we hear many times from adults with anorexia and bulimia. Adolescents also have difficulty in describing the amount of food that they eat. And one of the things that we use to diagnose a binge eating episode, whether that's with bulimia or binge eating disorder, is specific quantities of food that the person has consumed in a specific amount of time. And again, adolescents are not good with specifics. They're very, very generalized in their thinking. Finally, it's very difficult to determine whether self-evaluation is unduly influenced by weight and shape, which is one of the criteria for anorexia, in a patient who has, at best, a fragile and fleeting view and concept of who she really is. Self-identity and formation of self-identity is something that goes on, and it is a major developmental task between the ages of 15 and 25. So we have many challenges with our current system of diagnostics when it comes to identifying adolescents with eating disorders. I'm going to turn now to reviewing some of the common signs and symptoms. These are great to share with parents, teachers, coaches, anybody really who spends time during the day, during meal times, with children and adolescents. Constant adherence to increasingly strict diets, regardless of weight. Food refusal. Kids, saying, I'm just not that hungry. I have homework to do. I'm going to go do my homework instead. Or I'm going to meet with, so-and-so from my class to work on a project, and doing that during dinner time when historically dinner time, the family has eaten together. Many times in our culture today, families don't eat together anymore because, two of the kids have practice on one night and the mom has something else on another night. So that's another piece that can be difficult to assess because many times families aren't eating together. Habitual trips to the bathroom immediately following eating. Floaties in the toilet and other remnants of emesis in the bathroom. Secretly binging on large amounts of food, finding wrappers, finding excessive amounts of trash, bags, containers, either in the child's room or in the garbage container. Hoarding large amounts of food, kids that bring food to their rooms. Developing food avoidance under the guise of medical conditions. And this is something that also is very, very fostered by our culture today. Almost everybody I know has tried. Granted, I know, eating disorder professionals and people in recovery, but lots of people that I know have said, I think I'm gonna, go gluten-free, because I hear that that'll make me less tired, it'll make me think better. So this is very much supported and alive in our culture today. And for a kid with a predisposition to an eating disorder who's developing a full-blown eating disorder, this is something they glom onto. I think I'm lactose intolerant. I can't eat dairy. I can't eat cheese. Let's X out that whole group of food. Or I think I have a gluten sensitivity. I think I'm irritable, Mom, or I think I'm, I think I'm getting B's instead of straight A's in school because when I eat carbohydrates, the whole class, I just don't think straight. And parents many times don't know. They'll take them to a doctor, and a doctor will say, yeah, why don't you try it? That's a good idea. Let's give that a go for about 6 months and see what happens. And also, if you're having trouble concentrating, why don't I give you some Adderall? So now you've cut out all the carbs in your diet, and you're on a stimulant that suppresses your appetite and increases your metabolism. It's a setup for complete disaster. Abuse of laxatives, diuretics, or diet pills. Unfortunately, many times kids get these from their parents' medicine cabinets. Another thing that kids will abuse and misuse is thyroid medication, Synthroid. Many adolescents know, they can get on the internet like that and get a whole list of medications and substances that decrease their appetite. And if they have a parent who's hypothyroid and there's Synthroid sitting in the medicine cabinet, that's another substance that they may be misusing in the service of their eating disorder. So abuse of prescription stimulant medications. They may have a brother or a sister on Ritalin or Adderall. It's very, very easy, unfortunately, in middle schools today and high schools to buy Adderall. Many kids are selling Adderall and Ritalin at schools. And these are all commonly used by adolescents with eating disorders, both for academic enhancement and for furthering their eating disorder. Some other signs, behavioral and cognitive. Withdrawal from family and friends. These are diseases of isolation, largely. Most adolescents don't go out and starve with other adolescents. Most adolescents, college kids do this, but most adolescents don't go out and have, binge purge parties. This is something that we've seen on college campuses in sororities. But typically, these are behaviors that are done in isolation with a whole lot of secrecy and shame. Avoidance of meals or situations where food may be present. So, coming late to family events, going late to social events where the dinner portion of the event has already passed. Preoccupation with specific aspects of one's appearance. This is one of the symptoms that people start to experience sometimes as early as first and second grade. Talking to young adults with eating disorders and asking them, it's insufficient to say, when did your eating disorder start? Because they'll usually tell you about 5 years after it actually started. So it's good to ask, well, when's the first time you ever, had concerns about your body or about food? And many times the answer is, I think I was 7 years old or 8 years old, and just driving to school with my mom wearing shorts, I just looked down at my thighs and knew they were too big. And then from that point on, I have always had a problem with my thighs being too big. And usually it's the thighs or the stomach or the butt. It's never the hand. Okay. Obsessing over calorie intake and calories burned via exercise. This, again, is something that's very well supported by our society. There are all sorts of fancy technological wristbands that tell you exactly how many calories you burn in a day. There are, schools that support this. There are organizations that do, fitness challenges with their employees. So this is very, very widely supported in our community. It's pretty common these days to go to a restaurant and every single food item listed has the amount of calories in it. So we are unfortunately, diet obsessed, weight and body shape obsessed culture. Refusal to eat, this is usually further on in the progression of the illness. typically by the time it gets to a kid refusing to consume food, the parents are, at least at a gut level, well aware that there's a problem. Denial of hunger, very, very common. Excessive exercise, this too, very well supported by our culture. You know, your kid runs 3 miles every day. Wow, that's great. How healthy. And if this is a kid who has an eating disorder, even if it's not, for a 14-year-old to be running 3 miles every single day, it's probably something going on because that's not normal. Eating only a few certain safe foods. As soon as parents start hearing, any, good, bad, safe, unsafe language coming out of their kid's mouth about food, it's usually a sign there may be a problem. Rigid meals or eating rituals, food rules beginning to take hold, and then eating behaviors such as cutting food into tiny, tiny pieces, spitting food out after chewing, moving food around on the plate and spreading it out to make it look like you've eaten when you really haven't, those sorts of behaviors. There are a whole lot of physical signs of anorexia as well. And many of these go unnoticed or get explained off as other stuff. Underweight, emaciated appearance, many times that's looked upon as a good thing in our culture. Fatigue, dizziness or fainting, chest pain or palpitations. Most adolescents who are experiencing this aren't going up to their parents and saying, God, I haven't been eating so much lately. I've been working out 2 hours every day and my chest hurts sometimes. They don't come forward and say that. They may say that to a pediatrician or a family practice physician. And the family practice physician many times will say, well, your vital signs are normal, your labs are normal, so maybe it's anxiety. Or, it's probably not, maybe it's just growth pains or costochondritis. Brittle nails, orange tinge color to the skin, beta carotene levels increase in acute starvation states. Thinning or falling out hair, menstrual irregularities. Again, this is hard to assess in an adolescent, particularly if she's close to onset of menses, when many times in the first year of having menses, menstrual periods are irregular. If she's an athlete, it's very common for menstrual irregularities. So again, hard to know what to pin it on. Many times it gets pinned on, well, she just started her period, at the age of 17, 4 months ago, so maybe it's just that. Or, well, she's an athlete, so we know it's pretty common in female athletes to have some irregularities in their periods. Baby fine hair covering the face and body. Cold intolerance. When we lose our layer of insulation, we're no longer able to tolerate temperatures that don't feel cold to most of us. Attention deficits, the brain shrinks in anorexia. All muscle mass and all tissue mass in the body shrinks. And unfortunately, when adolescents get attention deficits or start having problems with their cognitive functioning, the first thing that people think is, oh God, I wonder if my kid has ADHD. I don't want them to fall behind in school. I better get them in to see somebody and get them on medication that will allow them to be on a level playing field with all of their peers. Seizures, again, usually a later manifestation, but hyponatremia or low sodium levels can lead to seizures in this patient population. With regards to behavioral signs of bulimia, constant dieting, hiding food or food wrappers, eating in secret, eating to the point of discomfort and pain. Usually the binge eating episodes are done in private, but one of the things I tell parents to look out for is erratic behaviors with food. So one day the person is eating healthy and won't have anything bad, and then the next day the person has 3 pieces of cake after dinner for dessert. So the vacillations in a person's relationship with food is many times one clue that can be used to identify bulimia and bulimic behaviors. Self-induced vomiting, laxative use, excessive exercise, and frequent trips to the bathroom. Oops. Physical symptoms of bulimia, tons and tons and tons of digestive issues. So indigestion, constipation, we see that both with bulimia and anorexia, and many times it's a huge source of discomfort, and one of the things that adolescents and young adults will come forward and ask for help with. Damaged teeth and gums. Dentists are a great gatekeeper and potential referral and interventionist for adolescents with eating disorders. Unfortunately, they have even less training than most primary care doctors when it comes to how to talk to people about having an eating disorder. Whenever I go to a new dentist, I let them know what I do, and I say, you know, how much bulimia do you see? Or how much anorexia do you see? And they're like, oh God, a ton. Well, what do you say? Like, what do you say to the patient or the parent when you see it? Oh God, I would never say anything like that to somebody. You know, I would never mention that. Well, you need to. So there's, you know, in the medical profession and in the dental profession, there's this like fear of, you know, I might get stabbed in the face if I tell the patient I know she's purging. Just because people aren't educated and people don't know how to talk to patients when they see the signs and symptoms of these illnesses. Another thing you can see is scarring on the back of the hands and fingers, something called Russell's sign, if a person is purging. Swollen salivary glands, chipmunk cheeks. With some patients, this is very, very marked. I run a couple of process groups back at Timberline Knolls, and with some patients, I don't even have to ask them if they've engaged in purging that day, because it literally shows up in their face. Menstrual irregularities, heartburn, a lot of reflux symptoms, and dizziness or fainting. So eating disorders are multifactorial, complex illnesses. They come from genetic predispositions, environmental factors, medical predispositions, life experiences, and in the presence of sometimes very substantial psychiatric comorbidities. Some of the risk factors. We know that there are genetic influences. It's estimated that there's about 50% heritability with eating disorders. Family history. If you have a first-degree relative who has an eating disorder, you're at a much higher risk to have an eating disorder yourself. If you have a parent who has a substance use disorder, you're at a much higher risk of developing binge eating disorder. Adverse life experiences, early developmental trauma in particular. Personality traits. We know that people with eating disorders have high titers of perfectionism, drive for thinness, obsessionality, and self-objectification. Culture and media. This is a huge, huge problem in our country. Most people don't realize that, I gave a trauma and eating disorders talk a couple weeks ago, and a doctor came up to me afterwards, and she was like, I was in Africa with one of my colleagues doing some, missionary work, and this colleague of mine was like pretty obsessed with, they fed us very, very well, all of this, rich, very rich ethnic food. And she was pretty obsessed with like all that she was eating, and said at one point to the people that were hosting us, oh, no, I'm gonna, I've been putting on weight, please, no more food. And the person she said this to was entirely offended and couldn't understand what she was saying, because in his country, if somebody's putting on weight, it means that it's actually a really, really good thing, and people like that. There's a high prevalence of HIV and AIDS in the country, so when people are losing weight, it's usually a sign that they're sick. Unfortunately, in our culture, it's the opposite. So culture and media have a huge impact on the development of eating disorders, and it's probably the last thing that's going to change. So when we're looking for interventions and ways to prevent eating disorders, we need to work on that. But as a parent of somebody with an eating disorder, the family culture, the culture in the house, the foods that I'm bringing in or not bringing into the house have a much more immediate effect than waiting around for People magazine to start putting people with diverse body sizes on their covers. Sports, another risk factor. People who are doing endurance sports or aesthetic sports are at greater risk of developing eating disorders. Some of the biological markers. Kay's group at the University of Pittsburgh has showed linkage to the serotonin transporter gene. There have also been groups showing linkage to the dopamine transporter gene and variations in these genes associated with higher rates of anorexia. Family and twin studies looking at heritability show a substantial amount of heritability. There's a 7 to 12-fold increase in prevalence of eating disorders in relatives of an eating disorder proband. There have been functional brain imaging studies showing irregularities and dysfunction in certain brain circuitry, altered temporal, frontal, and limbic lobe activity in anorexia nervosa. There was also in 2011 a Yale study showing implicating the same neural circuits for binge eating disorder and bulimia that we see in addictions. So the brain's reward center and pleasure centers. Some of the health risk factors for adolescents. These are illnesses that go far beyond food and go far beyond just a person's weight. Adolescents with eating disorders had elevated risks of anxiety disorders, cardiovascular disorders, chronic fatigue, stimulants help with that, chronic pain, narcotics help with that, depressive disorders, limitations in activity, infectious diseases. One of the effects of starvation is it suppresses our immune systems. Our body can't make white blood cells to fight off infection. Insomnia, neurologic symptoms, and suicide attempts. Problems with eating or weight during adolescence predicted poor health outcomes during adulthood, regardless of whether or not the person had a full diagnostic eating disorder. Only 22% of the adolescents of this study with current eating disorders had received treatment within the past year. So again, many of these adolescents are receiving some sort of health care and some sort of treatment. Very, very few of them are receiving it by eating disorder professionals specifically surrounding their eating disorder, because it's the last thing that they want to talk about or address. This is not a problem in their mind, it's the solution to their life stress. And we need to realize that as treatment providers. There have been a paucity of studies looking at health-related quality of life specific to eating disorders. And this was a review that looked at any study that did that. It showed patients with eating disorders have lower health-related quality of life than controls, not surprising. And the impairment occurs both in DSM-diagnosed eating disorders and also subthreshold eating disorders. I think as eating disorder professionals, and certainly as patients and family members, people think, well, it's sub-threshold or subclinical, so that's not so bad. But many of the sub-threshold syndromes have similar suicide risk and similar impairments in health and mental functioning. Family caregivers have reduced health-related quality of life. This is something we need to address in our treatment of the identified patient. The impairment in eating disorder patients is considerable, and eating disorder patients who receive treatment report improvements in all of this. So that's the good news. The bad news is that these are potentially fatal and very, very difficult illnesses to treat. The good news is that people can recover fully from their eating disorders. This is a recent study published in 2000, just this year, earlier this year, looking specifically at health-related quality of life in adolescents. And basically what they found was similar patterns as we see in adults with eating disorders. So the impairments are pervasive. They affect both physical functioning and mental functioning. And body dissatisfaction, in particular, was associated with poorer physical health than some of the other things that they looked at. More on health-related quality of life. Patients with eating disorders had poor health-related quality of life similar to those awaiting coronary surgery, candidates for heart-lung transplantation, patients selected for heart transplantation, and greater level of body pain and impairment in social functioning than those that did not have eating disorders. So when we say that these patients are sick and suffering, many times, people don't conceive them as, well, at least they're not sitting in a hospital waiting for a heart transplant. And really they are. This is a medical illness. It has just as much impact on a person's life as somebody, and a person's family, as somebody with a serious and major medical illness. And again, the good news is that these scores and the quality of life of our patients improve with proper treatment. So I want to turn now to screening for eating disorders in adolescents. And knowledgeable primary care physicians, which are unfortunately the minority, many times catch it first. Pediatricians really need to be screening for eating disorders as a part of their routine annual physical examinations and sports examinations. Monitoring, one of the best ways to do that is just monitoring weight and height on growth curves yearly and paying attention to it. So often in medicine today, the visits are 5 minutes, 10 minutes long, and instead of being able to review the growth chart with the patient and the family, it's just plugged into the computer and on to the next thing. Falling off the growth curve is a major red flag. Evaluating using standardized screening tools, such as the SCOFF, which we'll look at a little bit more in depth, is a great way to start looking for eating disorders. And then looking for the classic physical examination findings, laboratory findings, and EKG findings. So some of the assessment tools that physicians do use include the SCOFF. It's appropriate for ages 12 and up. And some further studies include inventories that look at beliefs around food and values. An example of that is the eating disorder inventory and the eating disorder examination. Attitudes towards self, food, family, or weight, the eating attitude test, which again is appropriate for adolescents. And then some more less formalized things like food diaries, mood logs, or even subjective units of distress scales. This is a slide that shows some of the specific child and adolescent tools and the different age ranges that it's shown to be accurate for and validated in. You can see that the eating disorder examination, which is one of the two that are diagnostic, is a pretty cumbersome and long tool to administer. It takes about 60 minutes. There is one that is available for children, ages 8 to 14, and it's a great tool, but I haven't met too many people that want to sit down, unless they're doing a research study, they want to sit down for 60 minutes and evaluate for an eating disorder diagnosis. I want to look a little bit more closely at the SCOFF and a system for physicians to evaluate patients for potentially an eating disorder. So there are multiple steps, and we'll go through each one of these. The questionnaire itself is very simple, takes about 2 minutes to administer. 5 questions. Do you make yourself sick because you feel uncomfortably full? Do you worry you've lost control about how much you eat? Have you recently lost 1 stone? Obviously, this was not created in the United States. 14 pounds in a 3-month period, which is a huge amount of weight for an adolescent. Do you believe yourself to be fat when others say you're too thin? Would you say that food dominates your life? And this captures not only anorexia, bulimia, but also what used to be called eating disorder not otherwise specified and binge eating disorder. And a score of 2 yeses or more indicates a likelihood of an eating disorder. Why is this a good tool to use? It's been shown to be effective internationally, many different countries, and it has a sensitivity of 82%, specificity of about 79%. It's the recommended screening tool by the American Academy of Family Physicians and also the American Medical Association. The next part of if somebody does answer yes to 2 or more of these, or even if they don't, and you have a clinical suspicion or a gut feeling, it's good to go ahead and ask some more specific questions. So specific history with regards to food, a person's relationship with body, a person's relationship with food, and a person's relationship with exercise. Weight history, most, least, how tall were you then, how long ago was that? What do you think your healthy weight is? Patients with eating disorders many times say, 20 pounds less than what we as clinicians would think their healthy weight is. Exercise, frequency, duration, level of intensity. Current eating habits, and you want to get into specifics. Picky eating, portion sizes, any ritualized behaviors, anything that's, good, bad, when a kid is using good, bad language around food, which unfortunately is common, that's something to pay attention to. Recent vegetarianism. Oops, thank you. Okay. Recent vegetarianism, major changes in food categories, like I don't eat lactose anymore, or I don't eat gluten anymore, or I've given up carbs. Many times these are behaviors they model from parents who are on a diet. Excessive non-caloric fluid intake, coffee, energy drinks, which are very, very commonly abused by people with eating disorders. Excessive gum chewing, again, a non-caloric food substances. You want to get a 24-hour food intake history. Many times it's get that from the patient, but also from the family. Ask about calorie counting, or fat gram counting, or carbohydrate counting. Binge eating, any purging history, patterns of diuretic, laxative, water pill use, any diet pills. These are very, very easily obtainable over the internet, and kids are very, very savvy at using the internet to obtain them. Ask about constipation, any previous therapy. Most of the time, the answer is going to be no, and if they have had therapy, usually it's for social problems or depression. Very rarely is it, yeah, I had some really great therapy for my eating disorder specifically. Symptoms of other medical illnesses, hyperthyroidism, diabetes, malignancy, infection, inflammatory bowel disease. Also, we see quite a bit of patients who come in with things like Lyme disease. I don't have an eating disorder, and I'm underweight because I have Lyme disease. And it just makes me not want to eat very much. Or I have inflammatory bowel disease. and that's why I can't gain any weight. Sometimes these are actually co-occurring. If they have a medical illness, it doesn't necessarily rule out the eating disorder. Sometimes they don't really have the medical illness. Family history, it's always important, especially, we get patients from all over the country. We've started using video conferencing for family sessions, weekly family sessions with families, so we get a visual of families. Not always is the treating physician present when the family brings the kid in. So looking at what does the family look like, asking about that is important as well. Menstrual history, very important. Substance use, many times forgotten and very, very important. Use of steroids, important for boys particularly. Use of stimulants. Involvement with pro-Ana or pro-Mia websites. And history of abuse, many times also not asked. We want to do a very thorough review of eating disorder symptoms. Many of these we talked about before. So a very specific eating disorder review of symptoms is a critical part of doing the physical examination or doing just the initial assessment with the person. Physical exam findings, if you're a non-medical provider, these are not necessarily things that you're going to be assessing. But when parents come in and talk to you about some of the things that their primary care doctor has said to them, you're probably going to be in a better position to relate it to the eating disorder or not than many medical professionals. So if you have a patient who the parent come in and say, yeah, we took her to the doctor, and I know you said her heart rate was at 50 was low and abnormal, but the doctor said that was totally fine because she's a runner or she's an athlete. You'll be able to dispel that myth much more effectively, primarily because of your relationship with the patient and family and because of your knowledge than many physicians. Changes in pulse, drastic changes in pulse or blood pressure upon lying down and standing is a sign of dehydration. Hypothermia, which is a person is pretty far advanced in anorexia usually before we start seeing changes in their body temperature. It's a very significant clinical finding when it is there. So temperatures less than 96 degrees Fahrenheit. Cardiac murmur, about a third of patients with anorexia will have mitral valve prolapse. And that's really just a structural effect of a shrunken heart and cardiac tissue mass loss. Again, this is a fairly advanced and significant finding. Paroditis, or inflammation of the parotid glands. Sometimes there's obstruction that forms, which can be extremely painful and lead to infection as well. A whole bunch of oral findings, ulcers on the mouth, dental erosions, soreness around the edges of the mouth as well. Skin findings, dry skin. When you pinch the skin, it doesn't go back down quickly, it stays up and tented. Bruising or abrasions over the spine, lower back area from doing 1,000 sit-ups a day. Delayed pubertal development. So if you have an adolescent girl who is 16 years old or 17 years old and she hasn't not had menses yet, and there's no brain tumor, there's no hormonal reason, there's no other medical reason for that not to have happened, it's most likely due to insufficient food intake. Atrophic breasts, or post-pubertal atrophic vaginitis. Russell sign, again, which is the scarring over the knuckles. It's also important that not every person who purges uses their hands to purge. So if you don't see Russell's sign, it's not an indication that the person is not purging. Cold extremities. Capillary refill, if you press down on a person's nail and it does not come back to normal color quickly, that's a sign of hypoperfusion, decreased blood volume, and pretty severe dehydration. The orange color of the skin, which I mentioned before, sometimes you'll have edema in the extremities, swelling in the legs and feet. A lot of times that's due to low amounts of protein in the blood due directly to malnourishment. And flat or anxious affect. Anxious usually more than flat. Flat is, if somebody with anorexia is at the point where they have a flat affect, they're usually pretty far off in their disease. So diagnosis with DSM-5, there have been a couple of changes to the eating disorder diagnoses. We'll review specifics on that. With anorexia, characterized by self-starvation, abnormally low body weight, along with intense fear of being fat and disturbed body image. The requirement of low weight, thankfully, is now defined in the context of age, sex, developmental trajectory, and physical health, rather than less than 85% of ideal body weight. That's a very positive change. And amenorrhea also has been removed as a criteria, in part because it doesn't apply to boys and men, and also in part because many adolescents with amenorrhea get put on birth control because their primary care doctors think that that's going to protect their bones. And there's been no long-term studies that show effectiveness with regard to bone health for prescribing contraceptives. And unfortunately, if a kid is on that, it takes away a nice biomarker of ideal body weight, which is restoration of menses. With regards to bulimia nervosa, some of the changes in DSM-5, it no longer has subtypes. It used to be subtyped into purging and non-purging bulimia nervosa. And also the frequency criteria has decreased to 1 purging episode a week instead of formerly it was 2. Really, if any patient comes to me and says they're purging, whether it's 3 times a week, 1 time a week, 1 time every other week, it's something that I'm going to be concerned about and addressing. Binge eating disorder now has its own legitimate diagnosis, thankfully. And it's binge eating without the compensatory behaviors. And patients are often obese, not always. They have greater functional impairment, and they're more likely to develop metabolic syndrome than obese patients without eating disorders. The former feeding disorder of infancy or early childhood has been replaced with avoidant restrictive food intake disorder, primarily because we know it also can occur in patients who are young adults and even older adults. So this is not something that happens just in childhood. And it's people who restrict for reasons other than weight control. So some of those reasons might be dislike of the sensory characteristics of food, avoidance of the consequences of eating. Eating is a very grounding experience, particularly for trauma survivors who like to be away from their bodies and away from their feelings. They may avoid eating specifically for that reason. And then other diagnoses in DSM-5, atypical anorexia nervosa, subthreshold bulimia and binge eating disorder, purging disorder, which is research criteria, night eating syndrome, and then pica and rumination disorder. I think Dawn or Bob mentioned that I was on My Strange Addiction, and it was a pica patient who was compulsively eating toilet paper. Okay, so the initial mental health assessment. Again, we want to help patients understand the eating disorder diagnosis. We want to have a sense of their willingness to receive help. And for adolescents, one of the nice things is that they have parents who can make them receive help. For young adults or adolescents who are 18 years old or older, many times we lose that power, but a lot of times we still have that power, because who are they relying on for college money and car money? Parents. And parents have, many times they need help seeing that they have power in this area. You know, a lot of times parents will say, well, I can't do anything about it, she's 18. Well, yes, you can. Stop paying for college, you know, or stop paying for the car. Social functioning, we want to have a good sense of how impaired their social life is. And usually school is the last thing to go. Psychiatric comorbidity is critical to assess for and treat. Suicidal ideation, again, critical to always be evaluating for that. It's a major cause of death in patients with eating disorders. And then a history of any sort of abuse, physical, sexual, emotional, bullying, particularly around weight. Differential diagnosis, it's important to include other possibilities, gastrointestinal disorders, celiac disease. Many patients come to TK and say, well, I have celiac, so I can't eat bread. In order for that to be diagnosed, we want to make sure that we have documentation, laboratory. Biopsy is the gold standard. Many patients haven't had a biopsy of their bowel to diagnose that. Infectious diseases, human HIV, TB, which is very, very rarely seen these days. Endocrine disorders, diabetes. Many patients with diabetes have manipulate, especially adolescents, manipulate their insulin in order to dump calories. So just because they have this physical illness, diabetes mellitus, doesn't mean that they don't also have an eating disorder. Other psychiatric disorders, obsessive compulsive disorder. If their OCD is only about food, that's probably an anorexia nervosa diagnosis. Obsessive compulsive disorder is usually pervasive. Body dysmorphic disorder many times co-occurs with eating disorders. Depression. When a patient with anorexia also says they're depressed, or a parent says they're depressed, many times that's not depression. That's simply what looks like a mood disorder, but it's based on the fact that their frontal lobes are shrunk, they can't display affect, they have lower levels of neurotransmitters in their brain, and the cure to that and the treatment to that is not necessarily Prozac, but it's food and refeeding. Medical complications are enormous and can affect any of the body's organs. We'll talk in a little bit more depth when we review the lab abnormalities, but it affects the cardiovascular system, the nervous system, the endocrine system, the muscular system. All areas of the body are affected by this. I want to show this slide of brain volume loss. Many times patients with anorexia really, really value their brains. And you know, a lot of times you'll tell somebody with anorexia, you're not thinking straight because you've lost neurons. You know, like your brain looks more like a 60-year-old with early dementia than an 18-year-old. And they'll say, I know a lot of anorexia patients might look that way, but my brain doesn't. But this is an example of a normal control on your left and a patient with anorexia on the right. And the arrows show the widening water spaces in the brain, which is basically what expands when brain tissue shrinks. And it's important for us to realize, if we're working with a malnourished, underweight patient, that there's no amount of CBT or DBT or trauma work that's really going to be effective unless that person's brain is regrown first. So first and foremost, food is medicine. Okay. I'm going to skip over more of the medical complications that we've already discussed earlier in the talk. Some of the GI effects that can be very, very dangerous with bulimia include tears of the esophagus, esophageal or gastric rupture, which is very, very rare, but carries an 80% mortality rate when it does happen. One more bowel effect that I think we encounter a lot as eating disorder professionals is constipation. A lot of times we'll say, that's just your eating disorder talking, stop asking me for laxatives, I'm not gonna give them to you. It's so important to take care of bowel health for people in weight restoration phase or recovering from bulimia. One of the most negative consequences of that is bowel obstruction or perforation, which can lead to death. So don't discount it just as being from the eating disorder. Some of it may be, but there's also a very physical aspect of it that can be potentially fatal if we don't address it. On the physical exam, you want to make sure, a lot of physicians will send me a person's vital signs, their heart rate and blood pressure, without doing it in 2 positions. And that's the information that I need to determine hydration status of the patient. Temperature, very important. BMI, just to have a sense of where the person is. And then growth charts for children and adolescents. And then there's basic laboratory studies that we need. First of all, a blood count. Many times it's low across all of the different blood types. A complete metabolic panel. Primarily we look at potassium, which can lead to cardiac arrhythmias. Sodium and chloride, both can be low. Bicarbonate is usually high if somebody is purging. So these give us not only an indicator of cardiac risk, but also an indicator of what behavior the person is engaging in. And those are the minimum that we'd want to see before assessing what level of care is appropriate for a person. Amylase is a salivary enzyme that's many times increased if a person is purging. Can also be increased for other reasons, like excessive gum chewing or pancreatitis. Some of the other tests that are not first line, but that we want to know as well: pregnancy tests, thyroid function tests, sex hormone tests. And then always important to get an EKG. We want to make sure that, I have a patient who just came back to Timberline Knolls, and her outpatient, she was doing an IOP with a therapist who said, she's been purging every day, she's abusing laxatives, and I really just think she's doing this to get back to TK because she was attached to you guys. And that very well may be. There may be some component of intentionality to it, but guess what? Her heart doesn't care. Her potassium at 2.0, whether she's intending to purge and get back to TK or just purging because of her eating disorder, doesn't care. And she's at just as much medical risk purging every day and abusing laxatives, whether or not it's intentional. So it's important that we have this data and that we're not, continuing talk therapy on an outpatient basis with somebody whose heart rate is 45 and potassium is 2, because that's a ticking time bomb. And there will be somebody else today, an expert speaking on level of care, and treatment options as well. So I'm gonna end there.